I'm going to talk a little bit about shared decision making and then try and apply it to medical cannabis. So I'm sure your group know what shared decision making is, but this is one of the definitions, and it basically involves patients and clinicians working together in partnership to make the healthcare decisions for the patient. And it's a process that occurs through the consultation. So it doesn't occur just at the end, and it's really the process of the consult itself. And the clinician shares evidence-based information and listens to the patient's individual needs and preferences and values and exchanges, it's an exchange. And then together we mutually come up with a mutually satisfactory decision about a test or a treatment or whatever. So what should you expect for when you attend a doctor or another clinician if you're expecting a proper shared decision-making consultation? So there are obvious things about empathy and rapport and, a nice communication style. But one of the really important things that I think many clinicians think they do share decision-making, but they don't really. And that is that they should talk to the patient about the potential benefits and the potential harms or risks of the tests and treatments that are being considered. But not only that, they need to discuss the other options. What will happen if we do nothing? And those are really an important part as well. And you should expect that, and you should ask about that. And they should obviously actively ask about and understand your values and your preferences and, what your viewpoint. And often at the beginning, I like to understand what their conceptions of their problem is, what they think the cause is, because often there are lots of myths and misconceptions. And so as part of that process of the shared understanding, I try and address those myths as well. And, the doctor might have myths about the patient. So we need to share and exchange information. So that really brings me to medical cannabis. And what I want to do is I want to share the evidence about it. I want to share what patients' views are, and then we can discuss what you think maybe. And so just to set the scene, I just make sure you understand what cannabis is and what it isn't. So cannabis is any product of the actual cannabis sativa plant. And everyone knows that, it's smoked for its psychoactive properties. Cannabinoids refers to a group of different chemicals that can activate the cannabinoid receptor. And that includes the marijuana or the cannabis, but it can include a whole range of other types of neurotransmitters as well. And so you can actually extract parts of the plant to become medical cannabis, or you can make something synthetically, and both of these will act on the cannabinoid receptors. I'll talk a little bit in the next slide about these two components of cannabis. But cannabinoids are theoretically thought to improve perception of pain through both analgesic and anti-inflammatory properties. And it's through this endocannabinoid system that and these cannabinoid receptors are both in the central nervous system, they're in the peripheral nervous system, they're in our immune system, and also in our hematologic or blood system. So that's where those receptors are. And you can activate them by at least 100 different cannabinoids, which is in cannabis. And so you can imagine there's lots of them, and they might have slightly different effects on the body. The two main ones that we're interested in is this delta-9 tetrahydrocannabinol, or THC, And that does a whole lot of things chemically. And that's the one that gives you the psychoactive properties. So that's the one that people smoke marijuana who want to get a high. The cannabidiol, and I apologize for these names, they're hard. They work on different things, and you can see their tumor necrosis factor, which if people who on the call are on biologics or TNF inhibitors will know about. And they can act on those receptors without the psychoactive effects of THC. So people are now trying to develop cannabinoids that don't have that psychoactive component, but still have that component of trying to reduce pain and reduce inflammation. And there are many different ones that people are trying to develop. So that's what it is. What are the guidelines around the world say? So we know from guidelines in the oncology literature, so this is people who might have cancer pain. In the European Pain Federation, that second one there on the left, as well as other ones, including the NICE guidance, which is the UK one. On the right, it's the Australian Rheumatology Association guidance, and then the Australian Faculty of Pain Medicine guidance. And in all of them, they're very consistent that the state of the evidence currently is that we don't support the use of cannabinoids for pain, for chronic pain, and that's cancer pain and non-cancer pain. And really what we need are better trials, and the Australian Faculty of Pain Medicine even suggests that people should not be prescribed it unless they're part of a registered high quality trial that is trying to establish its efficacy and safety. So these statements have all been made based upon the best available evidence. So we have about use of medical cannabis for pain. And I'm going to share you that evidence now. And this is just a slide from, it's now a couple of years old, but we now have legalized medical cannabis in Australia, as I know you do in Canada and the US. And this is what's been happening with prescribing over time. So it's really taken off, and it's even higher these days. And what's interesting to note is 61% is actually for chronic pain. So there is a disconnect between what the evidence says and what's happening in practice. And I think that's partially driven by patient demand and what they feel might work for them. But it's also very important to note it's driven by vested interests, including governments who also distribute and make money from cannabis. And in Australia, a lot of it is done through telehealth. And there was an article even just this week about reports to the health practitioner regulators about usually young doctors that are prescribing cannabis without taking proper histories and the problems with that. There is also, I know in the US you can advertise directly to the public, but in Australia you can't. And every other week, the TGA, which is like the US equivalent of the FDA, are charging companies for unlawful advertising and direct-to-consumer advertising. So let's move on to what the evidence actually is. I was part of a group that wrote a clinical practice guideline in the BMJ in 2021. And as part of that, to develop that recommendation, we did a systematic review of the evidence and a number of other reviews, including looking at the harms and looking at patients' values and preferences. And there were three consumers who were on the panel, all of whom take medical cannabis. So they have maybe a biased view. And there might have been some biases. Some of these people on this panel also work in the cannabis setting. But this is what the recommendation came out with. And I'll explain this picture. So on this side, there's people are not offered a trial of medical cannabis, and on this side, they are offered. And you can make a strong or a weak recommendation. And we made a weak recommendation for giving people a trial. You can't make a strong recommendation unless you have high certainty evidence. And we only had low or very low certainty evidence. So that's the first thing to note. There was disagreement about this. And I, for one, wanted to do this. I wanted to do a week against. And I'll explain, you'll see why as we go along. And so down here is the weak recommendation reflects the high value placed on a small to very small improvement in self-reported pain, function, and sleep, and the willingness to accept a small to modest risk of mostly self-limited and transient harms. And I'll show you the evidence to how we came up with that statement. But it's fair to say the clinicians were all leaning towards weak against and moved to weak for, really based on the testimony of the consumers in the panel. So this is now the systematic review that we published, and I want to show the evidence. So we looked for randomized controlled trials that had to be medical cannabis or cannabinoids versus any non-cannabis control group. And people had to have pain. So it was our review was for chronic pain. So they had to have pain for a month or longer. And what we included were 32 trials, over 5,000 people. In 30 trials, the medical cannabis was oral, and in 2 it was topical. Of the 32 trials, there were 29 that had a placebo control, which is the highest form of evidence if you're looking for the true efficacy of a treatment. 28 were for non-cancer pain and 4 were for cancer pain. And of importance really is that the trials were all really short. So the longest trial was 5.5 months. Sometimes the trials were only a whole month and that's it. So we can really say nothing about the long-term effectiveness or the long-term harms, potential harms, beyond this trial evidence. In terms of what there was for rheumatological conditions within those 32 trials, there was a single trial in rheumatoid arthritis, included only 58 people, and it was a spray that had the combination of the cannabidiol and the THC, so some psychoactive stuff in there. There was a single trial in osteoarthritis, 320 people, and it was delivered through the skin, and it was comparing 2 different doses of the CPD. There was a single trial for chronic refractory pain related to the musculoskeletal condition, again, small numbers, and it was oral THC, so the THC component. And there was a single trial in fibromyalgia, again, only small numbers. So that was at that time in 2021, that was some evidence. I'll show you a little bit later. There's been a back pain trial since. And this is the results. And I'm going to walk you through this graph. So firstly, these are the non-cancer pain trials, and each row is a different trial. And this is the cancer trials, these 4 here. This is anything on this side of the dotted line is favors cannabis, and anything on this side actually favors placebo. And this graph is for pain. And so what you can see here, and this vertical line is 1 point. So these are all out of 10. And this dashed line is what we decided was the minimum difference that we thought would be important. So we thought a 1 point difference. So if you got the treatment and your pain score was 8 out of 10, and it went down to 7 out of 10, we thought that might be an important outcome. If it was less than 1 point, then we didn't think it was important. What you can see here is the summary of all of these trials here and the summary of all of these trials here. And the first thing you can note is that the pain improvement, the mean improvement in pain, was actually less than 1. And for non-cancer pain, it was 0.63. So that means people on average would have an improvement of about 0.6 out of 10 improvements. So if your pain was 8, it would go down to 0.76. No, 0.74, sorry, 0.74. So a very small improvement in pain. And you can see here that for cancer pain, the improvement was actually smaller. It was about 0.5 point out of 10. So that's the evidence for the average improvement in pain overall across all these trials. The other thing you can notice is these are the point estimates for each of the trials, and these are the 95% confidence intervals. And you can see that across the trials, the effect varied widely, being on this side of the line and on this side of the line, but that most of them crossed this point of no difference. And there were a couple of outliers like this one, for example, but most of them were pretty close together, and particularly for cancer pain, they were very close together. And some of this variability is going to be due to the quality of the trials. It's important to note that most of the trials were unblinded. So even when it was compared to placebo, if you're comparing placebo to a cannabis product that's got THC in it, then you're pretty much unblinding the patients because they'll get those psychoactive effects. So the bottom line is that even these trials where people knew what they were receiving, if they couldn't find a huge benefit, then really the true effect is likely to be even smaller than this. So that's for mean improvement. One of the things that you might ask is, well, is there a subgroup of people who have big improvement and more improvement than others in whom it might be of benefit? And so what we did was we looked at the proportion that might have at least a 1 point difference out of 10, assuming that a 1 point difference is important to the patient. And we found that very few, there's 10% of people would have at least a 1 point difference. So very few numbers of people would have a benefit out of 100 people that take it. 10 people might have a benefit of about 1 point. So still very small numbers, but some patients might still think that was worth a trial. This is the results for function. And for function, the effect was even smaller. So this is a score out of 100 now. And so there was a mean improvement of about 2 points out of 100. So if your mean function was say 40 out of 100. With cannabis, your function you would gauge at 42 out of 100, and probably you wouldn't be able to detect that small difference. So there's really minimal improvement for function. This is sleep quality, and again you can see that this is where we think the 1 point is, and you can see here that overall, which is this bottom line, there's it still crosses this no difference, but it's well below a 1 point difference, and it's actually a 0.35 difference in terms of sleep. And we found no improvement at all for emotional, social, or role functioning. So that's the results of the effectiveness side. This is the results for the harm side. So remember, these are all short-term trials, but we found a greater increased risk of dizziness. So 9% of people got dizzy within 3 months. And this was even greater. So over a quarter of people complained of dizziness in people who had more than 3 months follow-up. We also saw an increased risk of transient cognitive impairment, vomiting, drowsiness, impaired attention, and nausea. And importantly, these are just the short-term harms. And I guess if you're worried about all of these, you'd stop the drug and those things will go away. So they're not serious because you can stop them. They're not like they're going to be prolonged even after you stop. But I'll show you some evidence later that patients would still value an improvement in pain even if they had to put up with some of these side effects. Because we didn't know what the longer term effects are, I've just put this slide up here, which is the long-term adverse effects of chronic recreational cannabis smoking from epidemiologic studies that can look longer. And so we know that you can get dependence and you can get chronic lung infections and disease, psychotic symptoms, particularly in people with a family history, and that's really in heavy users, impaired education in adolescents, subtle cognitive impairment in long-term use. And then these are possible adverse effects, particularly lung cancers, problems in children if pregnant women smoke cannabis, depression, manic disorders and suicide, and in adolescents increased use of other illicit drugs. So we know that medical cannabis have all these effects. We don't know whether medical cannabis does because it hasn't been studied in the long term, but we can presume that perhaps some of this might occur. You know, the lung ones probably don't occur because they're not given as an inhalation. Some people think that the value, even if it may not improve pain overall, that maybe it would help to reduce opioid use, and certainly there's opioid epidemics everywhere. But unfortunately, the trials to date, it remains highly uncertain that it actually reduces opioid use. So there are at least 5 trials now and found that adding cannabis to opioids had little or no effect on pain relief or sleep, but it was likely to increase side effects. There have been a number of other systematic reviews. So there's one here, which is been done by a big pain group in the UK, also connected with Cochrane, like I am. And this is their review. And so you can see they divided into cancer pain, neuropathic pain, and then longer neuropathic pain. This is multiple sclerosis pain, multiple sclerosis progression, abdominal pain, carpal tunnel. I don't know why you'd need it for carpal tunnel. And this single trial of low back pain, which you can see here is a real outlier. And there are lots of troubles with this study. And you can see that pretty much it's the same as ours. This is -1 improvement. And you can see that most of them were around 0 or up to -1, except for this outlier. So they concluded that there's low or very low quality evidence. They found very few beneficial effects of the drugs or the various strains of the drugs that have been tested to date. And so, you know, they also wrote that it may work for a very small number of people and they should be closely supervised, and we need more studies, basically. So this is the review I told you about that we did as part of the guideline. And we did a systematic review of patients' values and preferences. We found 15 studies, and there was evidence for both positive and negative influences. So in terms of positive influences, and certainly this is true in my practice, that a lot of patients come and ask me if they should take cannabis, and then usually say they're not asking for themselves, but so-and-so said, or their daughter's pushing it, or a friend. And I think that really reflects perhaps the feeling of stigma, so negative influences, and that strong push from people who are seeing the patient suffer and trying to give them other suggestions, as we know we all do, you know, when we get together and talk about ailments and, have you tried this? Have you tried that? Most of them favoured a balanced ratio of this psychoactive component and the CPD component, or the high, just drugs that only have the CPD without the THC, and no one wanted the ones that are just THC. And this is what I meant before, that many value symptom relief even if they have issues. So I guess this is suggesting that many people do have these issues. They also thought that reducing prescription medicine was a motivating factor, but as I've said, there's very little evidence that that actually plays out. There are disincentives, including the concern about addiction and acting strangely, and there are problems with out-of-pocket costs as a barrier. So I know in Australia that legalisation has improved access, but it's still an unwieldy process and it's still expensive, and people still go to other markets to get their drugs, or they get cannabis because it's much cheaper. So finally, considering these uncertainties, what should doctors do? And that was something we posed in an earlier BMJ opinion piece, and when we wrote that opinion piece, it wasn't legal. Now it's definitely legal in many places for approved indications, but it's costly. We know there's high variability in values and preferences, and we still are unclear about the long-term adverse effects. And I personally worry about those long-term effects and whether they outweigh what I've shown you are currently, with the currently available products, very small benefits. So this is really where we come to shared decision-making, I guess, because often patients still want to try it. And I just wanted to finish with some of the practical issues. So if people are starting it, we should start as low as possible. We should use the CBD products in preference to THC, non-inhaled, and gradually increase the dose and the THC component. Think about prior cannabis use, because that might indicate whether you'll have an adverse event with medical cannabis. And then really think about its effects on younger people, and really whether we should worry about THC in neurocognitive development. We have to tell people to avoid driving, operating machinery, and also we shouldn't be giving it to people who are pregnant or planning to become pregnant. And that's the end of my talk.